Week 4, we are going to be looking at Chapter 35 today, the care of patients with cardiac problems. Please take some time to refresh yourself on these vocabulary words. There are some video links on the bottom of the speaker notes of this slide. And then I'm going to talk about it a little bit, but it's really important that you have an understanding of these terms in order to really comprehend and understand the material that we're going to talk about today and next week as well. Let's talk about the path of blood flow through the heart. So when the blood comes from the body, it is received by the right atrium, and this is the deoxygenated blood, and it comes through the superior and inferior vena cava. The right ventricle, then it goes into the right ventricle from the right atrium, where it's pumped into the lungs via the pulmonary artery. Then it comes back to the heart, and the left atrium receives the oxygenated blood through these 4 pulmonary veins. And then it goes down into the left ventricle, which is the largest and the most muscular chamber. That receives all the oxygenated blood from the lungs, from the left atrium, and then it goes ahead and it pumps the body into the systemic circulation via the aorta. So let's talk about the mechanical activity of the heart. We know that when we're auscultating heart sounds, we expect to hear this S1, S2 kind of lub-dub sound. When we have diastole, that's when the ventricles are relaxed, so they're dilated, they're bigger. That's the picture on the left. And you can see the ventricles themselves, they look larger. And that's when the heart has, the chambers can fill up with blood from the atria. In systole, the muscles are contracting, they're squeezing, systole, squeeze, and that causes the muscles to become smaller, and it forces or ejects the blood from the ventricles out to the body or into the atria or to the lungs, wherever they're going. Systolic blood pressure then is the amount of pressure or force that we generate by the left ventricle to distribute blood into the aorta with each beat, each contraction of the heart. And it really measures how effectively the heart pump functions, and also tells us how vascular tone or how the vasculature in our body is receptive to receiving the blood. If we have vasoconstriction, for example, the heart's going to have to pump harder, the pressure is going to go up. Versus if blood vessels are relaxed, then the heart doesn't have to push as hard to get that blood throughout the body. Diastolic blood pressure is the amount of pressure or force against the arterial walls during the relaxation phase of the heart. So this is where the chambers are dilated. That's why we have a lower number for diastole. So the systolic would be like your 120 over the diastolic, which would be your 80. And 120 over 80 would be kind of our ideal blood pressure. Cardiac output is the quantity of blood flow that's being pumped from the heart over 1 minute. It is comprised of stroke volume multiplied by heartbeat or heart rate. So let's talk stroke volume for a second. Stroke volume is the volume of blood that's being pumped out of the left ventricle with every heartbeat. What's the normal rate for adults? So the normal rate is 60 to 100 beats per minute. Stroke volume is dependent on a couple things. One, it's dependent on myocardial contractility, or how much force of cardiac contraction, how the cardiac muscle can contract on its own. So the more forceful, the more it can contract, the more blood it can inject. It's also affected by preload, or how much blood is in the left ventricle before it contracts. Preload happens at the beginning of systole. And then we have afterload, which is the pressure that's required to open aortic valves. So again, think of somebody pushing against a door you're trying to open. You have to push even harder to get through, to beat the resistance. So the left ventricle is trying to open the valve against the pressure that's already in the aorta to get the blood out to the rest of the body. And so we multiply that stroke volume times the heart rate. And the heart rate, if it goes up, right, then we have an increase in cardiac output right away. But if you think about it, the faster the heart is beating, the less time we have for those ventricles to fill, and so cardiac output can then go down. Ejection fraction, let's talk ejection fraction. So the heart never is completely empty of blood. The ventricles don't squeeze out all the blood with each beat, so they're never completely empty. The percentage of blood that's ejected from the heart is called the ejection fraction. So normally, the ejection fraction is between 50 to 70%. So 50 to 70% of the blood gets pushed out from the left ventricle to the aorta, out to the rest of the body. If we have under 40%, then that is going to potentially be evidence of heart failure. So I'm going to go back up to cardiac output. Think about what happens to blood pressure when cardiac output is decreased. It can drop below normal, so we want to watch for that in our heart failure patients, as we'll talk about. So now let's get into chapter 35. We're going to talk a lot today about heart failure. You could also consider it pump failure, because the heart is essentially a pump. It's actually two pumps. We have the left side of the heart, which acts as one pump, and then the right side of the heart that acts as another pump. So in heart failure, it's not that the heart stops working. It still works. It just can't effectively pump blood through the body. It can't maintain adequate cardiac output that meets the metabolic needs of the body, because this pumping action is impaired. It's not doing its job. So then the body loses out on oxygen and other vital nutrients, and this causes a decrease in perfusion. And what is perfusion again? It's that ability to transfer oxygen to cells. So that goes down. And this goes down in vital organs like the kidneys, the brain, peripheral tissue. So your heart's still beating, it's just not pumping well enough. And it can happen for a variety of acute reasons and chronic cardiovascular problems. We have three major types of heart failure that we'll talk about. The left side, the right side, and then high output failure. Please keep in mind that if one side of the heart fails, if one of those pumps fails, so say the left side fails, the right can keep going for a bit, but in time, the right side then will fail as well. So there are lots of causes of heart failure. Some are more specific to left side versus the right, but know that there are both modifiable and non-modifiable risk factors that can lead to heart failure. And you can look through these on your own. Don't worry too much, though, about memorizing this list, because we are going to talk more specifically about left versus right causes. Do know that systemic hypertension is the most common cause of heart failure in most cases, followed by changes in the structures of the heart, like valvular dysfunction, for example. And then the biggest cause of acute heart failure is coronary artery disease. Left-sided heart failure used to be called congestive heart failure, and still is sometimes used clinically, but it's characterized by a decrease in tissue perfusion from poor cardiac output, and as well as pulmonary congestion from an increased pressure in the pulmonary vessels. So think back to the path of blood flow. We go from the body to the right atrium, to the right ventricle, to the lungs, to the left atrium, and to the left ventricle. So if we have left-sided heart failure, the blood that should be going into the left atrium begins to back up into the lungs. So the lungs are really affected. We have two different types. There is systolic heart failure with reduced ejection fraction. It's also called forward failure. So the heart isn't squeezing hard enough during systole to squirt enough blood into circulation, to pump enough blood into circulation. When that happens, the preload increases with that decreased contractility, and afterload increases because we're getting all of this resistance peripherally from the vasculature, so like in hypertension, for example. So what happens then is the ejection fraction, or that percentage of blood that comes out of the heart every time the heart squeezes, drops from the 50 to 70%, which is normal, down to below 40% because the ventricles are dilated. So tissue perfusion decreases, right? The cells aren't getting the oxygen, the tissue isn't getting the oxygen it needs, and blood starts to build up in those pulmonary vessels. Systolic heart failure is often called forward failure because the cardiac output is decreased. So that makes sense then, right? It's forward. A lot of these patients are at risk for sudden cardiac death, and patients that have an ejection fraction of less than 30% are considered candidates for implantable cardioverters or defibrillators, ICDs. In diastolic left-sided heart failure, we call this heart failure with preserved left ventricle function. It happens because the left ventricle is not able to relax during diastole. And so when it can't relax, then it's not able to fill enough. It kind of gets stiff, and the ventricle can't fill with enough blood to ensure an adequate cardiac output. So we still have an ejection fraction more than 40%, but in time, the ventricle itself just wears out. It becomes less compliant. It has to work against so much pressure to take the same amount of blood compared to a healthy heart. So diastolic failure we see in about 20 to 40% of all heart failure, especially in older adults and in women who have this chronic hypertension, as well as undetected coronary artery disease. The signs and symptoms, as well as the management of diastolic and systolic dysfunction are pretty similar, so we'll kind of talk about them together. But just kind of be aware that there is a difference between the two. So we talked about the fluid pooling back into the lungs and the tissues not getting good perfusion, not getting adequate perfusion or enough oxygen. So we see a few different things then when we're doing our assessment of a patient that has left-sided heart failure. They are really short of breath, so activity tolerance is very, very low. They are unable to, they have this just unusual amount of fatigue. So things like climbing the stairs can just knock them out. Completing normal ADLs. They might have dyspnea, and that is just from this increase in pulmonary venous pressure and pulmonary congestion. So ask the patient, do you have shortness of breath? How long have you had it? How does it develop? Sometimes they'll say they can't catch their breath, or they're breathless. They also have exertional dyspnea, or dyspnea on exertion it might be called. And this is just where they kind of stop doing the activities they used to do because they're just so short of breath. They just cannot catch their breath. There's also something called orthopnea, which is dyspnea when you're lying flat in the recumbent position. So one thing we can do to assess for this is to ask the patient, do you sleep with a lot of pillows at night? Or do you sleep in a recliner? Sometimes patients will say that they all of a sudden are awake, feeling short of breath. This happens a couple times, or 2 to 5 hours after they fall asleep. So they're sleeping, and all of a sudden they're wide awake, because they can't breathe. And this is called paroxysmal nocturnal dyspnea. So what they'll do then is, and what you can instruct your patients to do if this happens to them, is to sit up, hang their feet over the side of the bed, or kind of walk around. So think about if you are sleeping and you fall asleep on your arm and you wake up and your arm is numb, is tingly, or if you sit in the wrong position for too long, you have that tingly feeling. So what works best to get the feeling back is to move that limb around, right? To kind of shake it out a little bit, walk around on that foot that's asleep, and that usually helps to wake your limbs up. It helps the patient too to get that feeling back. Weakness or fatigue with activity we talked about. They might say that they feel like their arms and their legs are just really, really heavy. So we want them to exercise. We want them to perform simultaneous arm and leg work. So carrying groceries while they're walking. So they're working both activities at the same time. And even though it's hard for them, we need to make sure that they're using their muscles so that they don't lose the ability to use their muscles, and so that they don't limit themselves even further. A lot of people just do that unconsciously, right? If you're fatigued or tired, without even really thinking, you're going to stop doing the things that make you more tired or make you more short of breath. We might see changes in heart rhythm or rate, and that's because we have this decrease in perfusion to the myocardium, to the heart. And so the patient might say they have some chest discomfort. They might feel palpitations or skip beats. They might have a racing heartbeat. And then as the amount of blood from the left ventricle being ejected diminishes, we have this hydrostatic pressure, right, that builds in the pulmonary venous system. And so then they have fluid-filled alveoli and pulmonary congestion. And so, of course, that leads to cough. And a lot of times patients say the cough is, like, it's an irritating cough. They might say it happens a lot at night. And it's usually not a productive cough, so they're not coughing up a bunch of mucus or anything. But as heart failure becomes severe, they might start experiencing frothy, pink-tinged sputum. And this is a sign of life-threatening pulmonary edema. And so we're going to talk about that in a couple slides, but you can associate frothy pink sputum as a pretty serious sign of heart failure. And pulmonary edema, always associated with pulmonary edema. We might have oliguria, which is a scant urine output, so the kidneys aren't being perfused, and so the patient's not going to have a whole lot of urine output. There's also nocturia, where the patient is at rest. We're going to see then, if our patients are having trouble with their kidneys, an increase in BUN, increase in creatinine. We said that they might be tachycardic, might have a irregular heart rhythm. So we're going to want to really watch the respiratory rate, the rhythm, the character, oxygen saturation. We're going to see an increase in respiratory rate, more than 20 breaths a minute. We want to assess the patient's mentation. Are they oriented to person, place, time? We can do a little mental status exam if we're concerned about this. It's important to have some concrete data because a lot of people are really skilled at covering up memory loss. But when the brain is not getting enough oxygen, then people are frequently disoriented or confused, especially in the elderly. We also might see an increased heart size. We might, going back to the lungs, we might auscultate for crackles and wheezes. Late inspiratory crackles, so when they take a breath in, we hear crackles, might indicate heart failure, but they're produced by the intra-alveolar fluid, and so they're, a lot of times we hear them first in the bases of the lungs, and then as the condition gets worse, it starts to spread. Remember that wheezes tell us that the bronchial lumen is closing, and that happens because the pulmonary vessels are just so big, they're pushing on it. So make sure that when you're auscultating breath sounds and you're hearing wheezes or you're hearing crackles, that you're documenting exactly where you're finding those. So, as we mentioned, acute pulmonary edema is a life-threatening medical emergency. And what happens is the left ventricle is failing to eject enough blood, and so as a result, pressure increases in the lungs. The increase in pressure causes the fluid to leak across the pulmonary capillaries and into the lung airways and tissues. So we want to be watching for, or assessing for, and reporting early symptoms. So crackles in the lung bases, dyspnea at rest, disorientation, confusion, especially in our older patients. Again, document exactly where you're hearing the crackles, because as the level of fluid progresses from the lung bases up higher into the lungs, that happens as the condition worsens. So we want to keep it in track of that. You're going to see in your patients extreme anxiety, right? When you can't breathe, that is a horrible feeling. Tachycardia, you'll see them gasping or struggling for air. And as it becomes more severe, then you might see the moist cough, or production of frothy, blood-tinged or pink sputum. The patient's skin might become cold, clammy, cyanotic. So it's an emergency. It's a medical emergency. If we do not intervene, the patient is basically going to drown. So if they're not hypotensive, then we want to immediately get them into high fowlers. We want to have the legs down, because having the legs down helps to keep the blood from going back up to the heart. If the blood goes back up to the heart, it's just going to end up in the lungs, right? So it's just going to bring more fluid up. So we're going to use gravity to help us keep the legs down. We want to get oxygen going. The priority nursing action is to actually administer oxygen, and we want to do 5 to 12 liters per minute. just by simple face mask. We want to apply pulse ox. We want to keep the patient's O2 above 90%. Sometimes, though, the oxygen's not going to resolve the respiratory distress. So you're going to need to talk to the respiratory therapy, the provider, whoever, for more aggressive therapy. So they can do like a CPAP or BiPAP ventilation. But the patient might even need to be intubated and might need to be put on a vent. Another thing that we're going to want to do is get rid of all that extra fluid. So we give diuretics, usually furosemide, to help to get that fluid off the patient. We can give them morphine to help to decrease that sympathetic nervous system response, right, to lower blood pressure and anxiety too. It can also help to decrease preload and afterload. We can give Digi or digoxin to help with cardiac output. And then we can also give some antihypertensives like ACE inhibitors, beta blockers to help to decrease that afterload. So this slide just shows a comparison between a normal lung with clear alveoli with no fluid buildup versus a lung with pulmonary edema, where the fluid's built up in the alveoli, leaking into the lungs. And so you can see how this could potentially, how the patient is drowning. They're not able to exchange air, instead it's just fluid. Let's review the path of blood flow through the heart again. So we go from the body to the right atrium, to the right ventricle. But in right-sided heart failure, the blood isn't getting further than the right atrium, right ventricle. So where does it back up? It backs up into the body. So when the right ventricle can't completely empty, then we have an increase in volume and pressure in the venous system, and that's where we're going to see this peripheral edema. So the most common cause is left ventricular failure. Remember how we talked about how the heart is like two separate pumps, and if one goes out, then so does the other in time. So the most common cause of right-sided heart failure is left-sided heart failure. It can also happen though if the patient has an MI in their right ventricle, and then the other reasons are usually related to the lungs. So pulmonary hypertension, COPD, ARDS. So those could also contribute. A client is diagnosed with right-sided heart failure. Which assessment findings will the nurse expect the client to have? This is a select all that applies. So please put me on pause, make your selections, and then you can hit play. All right, so let's review them together. The first, and let's just take the approach where we look at each one as its own true or false. So, peripheral edema. Without even going through the signs and symptoms, we should be able to infer that the patient will have peripheral edema, right? We know that if the blood's not able to get into the heart, it's going to back up into the body, and all that fluid has to go somewhere. So we will see peripheral edema. How about crackles in both lungs? Nope, so that one is more associated with left-sided heart failure. An increase in abdominal girth is associated. All that fluid can pool up in the abdomen. Ascites, we could see, yes, definitely increased fluid in the abdomen, around the organs. And then an increase in breathing also, right? They're all symptoms associated with right-sided heart failure because of the backup of fluid into the peripheral system. So when you're looking at right-sided heart failure symptoms and signs, you can think of swelling right up, right? So in the rest of the body, that's right, rest of the body, right side, it all comes together. So we see this systemic congestion because the right ventricle is failing, fluid's retained, and then pressure builds up in the venous system. And most of these signs and symptoms reflect that. You can see waking, they can retain a lot of fluid. And we can assess for pitting edema, but it can take 4 to 7 liters of fluid, or 10 to 15 pounds before that pitting edema actually occurs. Edema usually starts in the lower legs, and then it can move up the thighs and the abdominal wall. The patient might notice that their shoes are fitting tighter, or that when they take their shoes and socks off at night, they see indents on their feet. Maybe they can't wear their rings anymore because their hands and fingers are swollen. A lot of times, like I said, it is dependent, meaning that it's in patients that are ambulatory, it's usually in their ankles and in their legs. But think about your patient that is restricted to bed rest. So what's dependent there? The sacrum, right? So they can actually have fluid accumulating there in the sacral area. They can have an enlarged liver due to congestion. Ascites, again, is just that increased fluid in the abdomen and the space around the organs. And so we can measure abdominal girth, and that can happen from severe liver congestion, where the liver is actually leaking out this protein-rich fluid. And abdominal fluids can reach volumes of more than 10 liters, which is over 20 pounds. So that's a lot of pressure. It can lead to nausea, anorexia. That can be a direct consequence of liver engorgement or congestion from all that fluid that they're retaining. And then it's also placing pressure, right, on the stomach and intestines, and so the patient might feel full early. They might become malnourished. They might have what we call diuresis at rest. And so diuresis, remember, is an increase or an excessive production of fluid, so the body's making more urine. At rest, the fluid in the peripheral tissues starts to move again, and it's able to be excreted. So the patient describes waking up a lot at night to urinate. Polyuria, right? Frequent and excessive urination. We want to make sure that we're asking them a history about nutrition, right? Talk to them about the use of salt, what types of foods they eat, because this is going to come into play where they're probably going to have to be on a fluid restriction, a sodium restriction. And the patient, too, might say that they have just this increased thirst. They drink excessive amounts of fluid, like 4,000 to 5,000 mils a day. And that's related to that sodium retention. In high output failure, heart failure, it can happen when the cardiac output remains normal or above normal, which is unlike the left and right-sided heart failure, right, where there's usually low output states. But in high output failure, it's caused by an increased metabolic need or hyperkinetic condition. So the demand from the body is just unusually high. So some examples would be like septicemia, having a high fever, anemia, where the body has too few oxygen-carrying RBCs, so the heart has to work harder, and then hyperthyroidism. And in hyperthyroidism, we have an increase in the overall metabolism, so the demand is higher. And this type of heart failure it's not as common as the other types. When we have insufficient cardiac output, what do you think the body does? If you guessed it compensates, then that is right. The thing to note, though, is that although these responses might increase cardiac output initially, they're really just band-aids, and in time, they can actually cause more problems with the heart's pumping ability. So the sympathetic nervous system is one compensation method. This is our fight or flight, right? It increases the catecholamines, which are hormones that the adrenal glands make, like epinephrine, norepinephrine, dopamine, and they're made as a result of tissue hypoxia. And this happens right away. They're ready to go as soon as they detect a problem. And stimulation of this adrenic receptor causes an increase in heart rate, and it also causes an increase in blood pressure from the vasoconstriction. So the vessels get tighter, get smaller. Not smaller, they tighten up. The lumen, though, gets smaller. But an increase in heart rate causes a higher oxygen demand by the heart muscles themselves. And if the heart has poor perfusion, then heart failure can get worse. So if the heart needs oxygen too, it's also tissue that needs oxygen. So it can't just work under no oxygen. Also, vasoconstriction causes an increase in resistance from the body. So the heart has to work harder and stroke volume may end up going down. We also have the renin-angiotensin-aldosterone system, or the ROS activation. And if you can think of angiotensin as angiotension, right, applying tension, applying pressure, it causes vasoconstriction. So when angiotensin 2 specifically causes vasoconstriction, it also ends with aldosterone secretion, remember? And aldosterone causes sodium and water retention, which would also increase blood pressure, putting a higher demand on the heart. There's also different chemical responses that contribute to ventricular remodeling. And this is bad. It's bad because ventricular remodeling or changes lead to the ventricles becoming larger, generally, And the shape of the ventricle itself becomes more globular, and less oval shaped, which we want the oval shape. We have the natriuretic peptides, and natriuretic peptides are neurohormones, and they work to promote vasodilation, as well as diuresis through sodium loss in the renal tubules. So we're trying to get rid of the sodium, get rid of the fluid. The B-type natriuretic peptide, or BNP, is produced and released by the ventricles when the patient has fluid overload as a result of heart failure. So it increases with age and as renal function worsens. And we'll talk later about how it's actually a pretty good marker of heart failure. And the last one is myocardial hypertrophy. And so that's just an enlargement of the myocardium, the muscles of the heart, with or without chamber dilation. So maybe the chambers get bigger, maybe not, but it's another compensatory mechanism. The walls of the heart get thicker, so they have a little more muscle mass, so they can squeeze harder, right? And that increases cardiac output. However, the cardiac muscle, when it's bigger muscles demand more oxygen, right? And so circulation can't give enough blood supply to that muscle. So often a hypertrophied heart is slightly oxygen deprived. So all of these compensatory mechanisms contribute to an increase in the consumption of myocardial oxygen. And when the demand for oxygen increases and the myocardial reserve has been wiped out, then we start to see these signs and symptoms of heart failure. And you could go ahead and read through this heart failure assessment review. We've talked about much of this already, and there really isn't anything on here that is too surprising. How do we diagnose heart failure? How do they find it? So the best way is to do an echocardiogram. An echocardiogram is basically like an ultrasound for the heart, right? And so we can see the structures, we can see the valves and how they're working. We can watch the blood flow through the heart in real time, and we can use this as a tool to measure ejection fraction, right? And keep track of how the patient is doing with that. So that's kind of the best tool. We can also take an X-ray. X-ray shows us pictures, right? Some of the structural things with the heart, with the lungs. We can do stress tests to show how the heart works while it's under pressure and how much the heart can actually handle. And then we have some different lab tests that we can do. So in clients that have shortness of breath, an elevated BNP can confirm that a diagnosis of heart failure rather than a problem with the respiratory system, right? So shortness of breath is a sign of different respiratory issues as well. But if we test BNP, then we can tell that it's actually associated with the heart instead. BNP levels also can tell us the aggressiveness of the treatment interventions. So we say less than 100 is no heart failure, 1 to 300 suggests that heart failure is present, greater than 300 is mild heart failure, greater than 600 is moderate, and greater than 900 is severe. So, I mean, you don't have to know those numbers necessarily, but just know that with BNP, as it increases, the severity of the heart failure is increasing as well. We also can look at electrolyte imbalances from complications of heart failure or as side effects of drug therapy, right? So if we're going to be giving patients diuretics, we're going to want to watch sodium, potassium, magnesium, calcium, chloride, all of the electrolytes. Also, any impairment of renal function from inadequate perfusion can cause an increase in blood urea nitrogen (BUN), serum creatinine. We can see a decrease in creatinine clearance levels. Hemoglobin and hematocrit tests we want to do to make sure that we can identify heart failure that might be the result of anemia. If a patient has too much fluid, the hematocrit levels might be low. So lots of different tests here. We can also check out the CRP for inflammatory markers. We want to watch ABGs for oxygenation, right? Also, we could do a UA. So a urinalysis might reveal proteinuria and high specific gravity. And actually, microalbuminuria is an early detector of decreased compliance of the heart, and we can even see this before the BNP starts to go up. So it kind of acts as this early warning sign. So the primary health care provider might know that the heart's experiencing some early signs of decreased compliance way before the patient is actually showing signs and symptoms. They can also do some invasive hemodynamic monitoring. You will learn a lot more about that in Nursing 3, but hemodynamic monitoring, we usually see increases in central venous pressure, increased pulmonary wedge pressure, increased pulmonary artery pressure, and decreased cardiac output, which we do know about. We also can see mixed venous oxygen saturation, and that's directly related to cardiac output. Again, you will talk about that more in Nursing 3. We can also do an ECG because we know that hypoxic cardiac tissue can lead to dysrhythmias, so we can do an ECG as well, but it doesn't tell us like how bad the heart failure is, it just tells us if there's a problem with rhythm. So how do we intervene in our patients that have heart failure? We do a lot of different things. Fluid restriction is one thing we want to do, so stick to like 2 liters a day. We also do sodium restriction, so think about what foods contain sodium, right? Canned foods, processed foods, smoked foods, soups, bakery, baked goods, all those things. We want to make sure that our patients are avoiding those and monitoring how much sodium they're taking in every day. We're going to have them do daily weights. And daily weights, we're looking for fluid retention, right? So we want them to report anything over 2 pounds a day or 5 pounds in a week. And they should take their weight at the same time every day, preferably in the morning before they've had breakfast or done much that day. We want to provide therapeutic support and instill hope. Because this is a difficult thing for the patient to go through, so be present for them and be available to listen. The patient might need to be placed on a CPAP to help with breathing. They may need to do cardiac resynchronization therapy, possibly heart transplant, right? So heart transplant is a possible option for clients who have the end stage heart failure. Know that they'd have to do immunosuppressant therapy first to help to prevent rejection. And really, eligibility, it's not just for anyone that's at end stage. It depends on things like their life expectancy, how old they are, how they are psychosocially, and then they can't have the presence of drug or alcohol use disorders as well. The patient might have a ventricular assist device, and that's a mechanical pump that just helps a heart that's too weak to pump blood by itself. So it's used in clients who are eligible for heart transplants and who have this severe end-stage heart failure, but are not candidates for heart transplants. Really, we want to encourage activity, as we mentioned, so encourage them to get out, to move around, even if they're tired, to try to stay strong, to keep moving. We also, positioning is really important, so we're trying to maximize ventilation. Think like high fowlers, right? It's easier to breathe. There's a bunch of different meds, and I want you to know and think about how these meds help our patients with heart failure. I will be talking about this more in a different PowerPoint. And then there's a self-management tool on table 35-4 in your book that you can check out too, just ways that you can help your patient, education you can provide them to help themselves. We have an 84-year-old client with heart failure that presented to the ED with confusion, blurry vision, and an upset stomach. What assessment data is most concerning to the nurse? Okay, the answer here is A, digoxin or lanoxin therapy daily. Confusion, blurry vision, and upset stomach are all symptoms of digitoxicity, which is common in older adults, and it requires immediate treatment. The other answers are important assessment data, but do not indicate immediate connection to how the client is presenting. So remember that digoxin is an inotropic agent, and it's used to increase contractility and thereby improve cardiac output. So before you give digoxin, there's a couple things that you need to remember to do, right? We want to make sure that you're taking an apical heart rate for 1 whole minute, and we want to hold the medication if the apical pulse is less than 60 a minute and notify the provider. A lot of times we want to teach clients as well that they should be counting their pulse rate, and if it's irregular or outside the limits, usually less than 60 or greater than 100, we hold the dose and contact the provider. They should take it at the same time every day. They should not take it at the same time as antacids, right? They need to keep the two separate by at least 2 hours. And then they need to learn to report the signs of toxicity, including fatigue, muscle weakness, confusion, and loss of appetite. The other thing they need to do is make sure that they're having their digi levels checked, right? Because they can reach toxic ranges, and potassium levels checked as well. How do angiotensin-converting enzymes, or ACE inhibitors, such as enalapril or Vasotec, work to reduce heart failure? This is a select all that applies, so please put me on pause, make your selections, and then hit play to see if you're right. So ACE inhibitors, remember they prevent the conversion of angiotensin 1 to angiotensin, or remember to think of it as angiotensin 2, because it's a powerful vasoconstrictor. It provides tension. It squeezes the veins shut, constricts the veins, or the vessels, I should say. So the result is this: if we're preventing that because of our ACE inhibitor, then the result is this systemic vasodilation. So it reduces the preload, or the volume of blood that's entering the left ventricle. It reduces the afterload by reducing that resistance to the left ventricle contraction from the vasculature in our heart failure patients. So it's A, B, and D. ACE inhibitors do not promote the excretion of sodium in water, and they don't cause an increase in cardiac contractility or contractility, or block the sympathetic nervous system to the heart. Remember in our ACE inhibitors that we should watch for hypotension, right? Especially the first time the patient has had an ACE inhibitor. We should keep our eye out for a dry cough, which is a very common side effect of ACE inhibitors. We need to watch for angioedema, which is just the swelling of the tongue and the throat. The patient might also report a decreased sense of taste or have a skin rash, and that could all be indicative of an allergic reaction. And then we also want to watch for an increase in potassium. What lab test should be ordered for a client related to their order for furosemide or Lasix? Select all that apply. So let's go through each one. A, magnesium. Yes, so furosemide is a potent diuretic, especially if we're giving it IV piggyback or IVP. So it may cause a loss of electrolytes like magnesium, sodium, and potassium. So you want to make sure that we're checking A, B, and E. Also, furosemide can increase serum glucose levels, which is an issue, right? So make sure that we select A, B, D, and E. We don't have to monitor CBC or coagulation studies when a patient's on furosemide. A 73-year-old woman is admitted to the tele unit with right-sided heart failure, type 2 diabetes mellitus, hypertension, and chronic obstructive pulmonary disease. When the patient arrives to the unit, you observe that her color is pale, she's becoming increasingly dyspneic, and she reports a new onset of chest discomfort. The patient's husband is very concerned because he thinks his wife is slightly disoriented. Her oxygen saturation levels are 88% on oxygen, 2 liters per nasal cannula. Using clinical judgment, what would you assess first? So the priority assessment here is gas exchange. Well, the patient has known right-sided heart failure. She's really showing signs of respiratory distress, which could indicate progression to left-sided heart failure. Remember that one side of the heart can only hold out for a while before the other side's affected too, and or pulmonary edema. So we want to assess lung sounds. We want to assess heart rhythm. We want to document when we're auscultating the precise location of crackles because the level of the fluid progresses from the bases of the lungs to higher levels as the condition gets worse. We want to watch her oxygen or monitor her oxygen as decreased oxygenation is likely contributing to her confusion. We also want to check blood sugar. What evidence-based actions will you plan to implement at this time based on your assessment? And what is the source of your evidence? So we want to provide the necessary amount of supplemental oxygen within a range prescribed by the healthcare provider because we want to maintain oxygen sats at least 90%, preferably higher. If the patient has dyspnea or shortness of breath, we want to place her in a high Fowler's position with pillows under each arm to maximize chest expansion and to help improve gas exchange. Repositioning and performing coughing and deep breathing exercises every 2 hours will also help to improve gas exchange and help to prevent atosclerosis. The decrease in oxygen level is likely contributing to her confusion, as I had mentioned. The patient's healthcare provider prescribes an initial dose of furosemide or Lasix, 40 milligrams IV push. What assessment will you perform to determine if the drug was effective? So we want to assess for improvement of lung sounds, increased urinary output, and relief of dyspnea. The patient's husband remains very anxious and requests to stay at her bedside. What will you tell the patient's husband about her condition at this time? Should the patient's husband be present during her emergency treatment? Why or why not? So we want to prescribe and provide, we want to provide as much information to the husband as possible. We want to explain the process of heart failure. We want to talk to him about the steps that are being done to help his wife improve. Allowing the husband to stay is going to be situation and agency specific and should really be based on the patient's needs. After 2 doses of Lasix, the patient's condition improves. What data will you document in the electronic medical record? Here we want to document assessment information, including specific locations of crackles, as well as the changes in the lung sounds and the breathing following the Lasix administration. We want to document urinary output and any teaching measures that we provided to both the client, the patient, and her husband. So infective endocarditis. When you see endo, think inside of the heart. It's an infection of the heart's inner lining, including the heart valves can be affected as well. And this infection can be caused by different microbes, virus, bacteria, fungi. They find their way into the bloodstream through a lot of different areas or reasons, ports of entry. They can go in through oral cavities during dental procedures or teeth cleanings, especially 3 to 6 months after the procedure. We're likely to see them that infective endocarditis has developed. It can happen through rashes, lesions, abscesses, through IV drug use, through the skin, through different and other infections in the GU, GI, or systemically. And it can also happen from surgery or invasive procedures, and that includes IV placement as well. But what happens is this bacteria builds up in the bloodstream, and it kind of clings to areas of insult. So in the heart, scar tissue, any structural abnormalities, any problems with the valves, the bacteria find their way there, and they just kind of hang out. They build up, and that can lead to valvular insufficiency. It can lead to an obstruction of the valve if the bacteria, the platelets, and the other fibrin that are all clumping together get big enough. And the clump can break free and embolize, which can cause big problems as well. So this picture just shows the infection inside the endocardium, the endocarditis, affecting the valve. Unfortunately, in infective endocarditis, a lot of times the patients go misdiagnosed or underdiagnosed. So there is a relatively high mortality rate associated with it. And in part it's because the infection, the signs and symptoms are pretty vague, right? So they tell us, the patient's feeling unwell, but it doesn't point to infective endocarditis. So we might see a fever between 99 and 103, They may have chills, night sweats, malaise, fatigue. Older adults may be febrile, though, so they might not present the same way that younger adults do, leading to the diagnosis getting overlooked. They might have anorexia and weight loss. The patient might develop a cough, joint and back pain. They might get what we call a new regurgitant heart murmur, and that happens from damage to the heart valves. We might see petechiae, or those little pinpoint hemorrhages under the skin. We might see splinter hemorrhages in the fingernails. So also what can happen, as we said, the bacteria and the fibrogen can build up and form a clot, and that can turn into an arterial embolism. And that arterial embolism happens in about half of the cases. If the infective endocarditis is on the left side of the heart, we'll see that embolism then travel to the spleen, the kidneys, the GI, the brain, the extremities. And on the right side of the heart, we'd see it then go on into pulmonary circulation. And so if you think again about the path of blood flow through the heart, it makes sense that that's the direction the clot's going to be sent. We also then can see a new onset of headache, or TIAs, which would be related to a left-sided heart or infective endocarditis. We might see Osler's nodes on the palms of the hand and on the soles of the feet, and these are really painful. They can last from hours to days. There's also something called Janeway's lesions, which are these flat, reddened maculae on the hands and the feet that can last from days to weeks. And then the most common thing that happens is that the patient will develop heart failure. So we want to assess for right-sided heart failure, and remember we can see that as peripheral edema, weight gain, and anorexia, and left-sided heart failure, which we could see by fatigue, shortness of breath, and crackles when we're auscultating breath sounds. So here are some images of the signs of infective endocarditis, the symptoms. So take a look and see if you can figure out what these are. Okay, so here, I don't know if you can see my cursor, this one here is petechiae, right? Those little pinpoint hemorrhages. And those pinpoint hemorrhages, a lot of times we see on the mucous membranes, the palate, the conjunctivae, and the skin above the clavicles. This one here are these splinter hemorrhages. So you can see these kind of brown, sometimes they're red hemorrhages. They almost look like splinters that have been kind of shoved under the patient's fingernail, and it's usually here on the distal third. Down here we have Janeway's lesions, right? So these we can see in our heart failure or in our infective endocarditis patients as well, and see they're kind of flattened. And then the Osler's nodes, which are here. So these are the really painful ones. They can be on the palms of the hand and the soles of the feet as well. So the most reliable way to test for infective endocarditis is to do a blood culture. We can look at anaerobic and aerobic cultures, and that can tell us if there is the presence of infection in the bloodstream. We can also do an echocardiogram, remember just an ultrasound basically of the heart to show any physical changes to the valves. And then the patient also might have low hemoglobin, might have low hematocrit. And remember that the normal range for hemoglobin in men is 13.5 to 18, and in women it's 12 to 16. Normal hematocrit for men is 40 to 55%. So in men it's 40 to 55%. Women is 38 to 47%. The patients are going to be prescribed some long-term IV antibiotics. A lot of times these will get started in the hospital and then they'll be discharged and they'll have to continue IV antibiotic use at home. Throughout their therapy on these antibiotics, we're going to be doing periodic blood cultures to see how well they're working. We're going to have the patient monitoring their temperature, taking a temperature every day to watch for signs that they have knocked the infection out. Would we want to give anticoagulants? No. So anticoagulants do not prevent vegetation or the clots that are formed in infective endocarditis from forming. So surgery, the client might need a replaced valve if the valve has been affected by and damaged. They might have to replace that valve, and in that case, then they might need anticoagulants. But it's not something that's just prescribed. For teaching, they're going to want to use proper oral hygiene, use a soft toothbrush, brush twice a day. They have to remind their healthcare providers of their endocarditis because there are guidelines for antibiotic prophylaxis. And so the patient that has a prosthetic valve, a history of infective endocarditis, they would need to then take an antibiotic prior to going in for dental cleaning, dental procedure. So we just finished talking about endocarditis, which is affecting the inside of the heart. Pericarditis is what we're going to talk about next, and that is that sac that covers kind of the outside layer of the heart. So the pericardium is that really thin membrane that surrounds the heart. It's actually a couple layers thick. There's some fluid in between, and what happens is in pericarditis is that there's an infection within that fluid, and that fluid builds up and it puts pressure on the heart from the outside. It can happen for acute reasons, so infective organisms, post-MI we might see pericarditis. Sometimes there's these acute exacerbations of systemic connective tissue disease. Lots of different acute causes, and then they can also happen for chronic reasons. So when we have ongoing inflammation, it can lead to the pericardium becoming thicker, and when the pericardium is thicker, the ventricles can't fill as full, so it results in heart failure. And we usually see this in patients that have tuberculosis, patients that have gone through radiation therapy, trauma, renal failure, things like that. When we're doing our assessment of pericarditis, we might see this precordial pain in the anterior chest, in the front of the chest, that radiates to the left side of the neck, the shoulder, or the back. And patients describe this pain as like grating, and it's aggravated by things like breathing, especially when you're taking a breath in. As we take a deep breath in, our lungs fill up with air, and that adds to the pressure that's being placed on the outside of the heart. It's also worse when the patient's in the supine position. And again, that just has to do with added pressure on the outside of the heart. And it gets better when the patient sits up. They might have a fever, chills, fatigue, malaise. We might hear something called a pericardial friction rub, which is like a scratchy, high-pitched sound. It's heard when we're auscultating heart sounds, and it's caused by when the two layers of the pericardium are rubbing together, and there's that inflammation. That's what we can hear. We also want to be monitoring for pericardial effusion, which is just the accumulation of fluid in the pericardium. And so what we might see is maybe there's signs and symptoms. If there are symptoms, we see things like shortness of breath, difficulty breathing or dyspnea. We might see discomfort when breathing or while lying down, or the orthopnea, chest pain kind of behind the breastbone or on the left side of the chest, as I said, and then just this feeling of fullness. The problem is that when the fluid accumulates quickly, it can develop into cardiac tamponade, which is a medical emergency, and we'll talk about that in a couple slides. We are going to want to do some labs for our patients with suspected pericarditis. We can do a CBC. We would expect to see elevated white blood cell count. We can do ESR, CRP, and the RF, the rheumatoid factor, and those just measure inflammation. They're all different inflammatory markers that we have in our body, and we'd expect to see an elevation there. We can check creatinine and bun to make sure that the kidneys are functioning appropriately, and then we can do blood cultures as well. We can do an ECG because a lot of times there will be dysrhythmias. Particularly, we'll see an elevation in ST segments or PR segment depression. We also can see AFib at times. They can do the echocardiogram or a CT scan, and here we can see the thickening of the pericardium, and that shows us that is in fact happening. For treatment, things like NSAIDs to help reduce inflammation, diuretics, digoxin, and they may need surgery. They may need a pericardiectomy, which is just a surgical incision that's placed in that pericardium. It can help to relieve some of that pressure. Rheumatic carditis is also called rheumatic endocarditis, and it's this sensitivity response that happens usually after a patient has had an upper respiratory tract infection with the group A beta hemolytic streptococci. It happens a lot of times too in patients that have rheumatic fever. We don't really know why this infection leads to this inflammatory lesions that end up forming in the heart, but we can see it across all the layers of the heart. And what happens from the inflammation is that the heart's not able to contract the way that it needs to. The pericardium or the outer layer gets thicker, and the valves can become damaged as well. So what happens, or what we see, are these little Aschoff bodies, or these small little nodes that are in the myocardium, and they get replaced by scar tissue. And so we know that scar tissue, when it's replacing cardiac tissue, affects the way that the heart's able to function. It may result in heart failure as well. But again, the most serious damage happens to the endocardium inside, affecting the valves especially. So what we might see, and again, it's one of the major indicators of rheumatic fever, so sometimes this inflammation is just telling us the patient has rheumatic fever. So we see an increase in heart rate, we can see an enlarged heart, or cardiomegaly. They might have a new murmur in their heart, and again, that's directly related to the changes in the valves. We can hear that pericardial friction rub. Pain, we might see changes in the ECG, prolonged PR intervals, and also heart failure, signs of heart failure. So what we want to do is to get the patient on antibiotics. We want to keep them hydrated. We want to give them meds, antipyretics, to help keep the fever down, encourage rest, and then they're going to have lifelong prophylactic antibiotics. So again, when they're going in for dental procedures and whatnot, they'll have to take an antibiotic first because the valves have been compromised. Depending on the severity of the damage, in time they might need valve replacement in the future. In cardiac tamponade or tamponade, this is the emergency. So this is where we have that really fast accumulation of fluid in the pericardium, putting pressure on the heart and causing a drop in cardiac output. So the slow accumulation is okay of fluid in the pericardium. When it happens slowly, the pericardium can stretch, and it can actually hold several hundred mils. In cardiac tamponade, it's just a small volume. It's like 20 to 50 mils, which is the size of a big shot glass of fluid, quickly accumulates in the pericardium, which causes a sudden decrease in cardiac output due to this sudden pressure on the heart. And so it can happen for a few different reasons, from trauma, from injury, sometimes a few days after a MI, aortic rupture. So what we're going to see is jugular vein distension right from the fluid. We're going to be able to measure for this paradoxical pulse, which is a systolic blood pressure that's 10 higher on inspiration than on expiration. So 10 millimeters of mercury higher on inspiration than on expiration. They'll probably have bradycardia because when the pressure is building, the heart rate ends up dropping. Shortness of breath, fatigue. When we're auscultating heart sounds, they're going to be muffled because they're underneath all that fluid. We can see hypotension. The blood pressure decreases because there's a lack of room for the ventricles to expand and take in blood. So that drops that diastolic volume. And remember, in diastole, that's where the heart's relaxed, and so the chambers are meant to fill with blood. But here, there's not enough room for them to fill as much as they need to. Stroke volume goes down too, and so we need to give the patient fluids. That's one of our main interventions, to get that fluid volume back, to get the blood pressure up. They'll usually do an echo or an x-ray to confirm. Sometimes though, it's not a ton of fluid, so sometimes it's really hard to see that's the problem. We'll do some hemodynamic monitoring to measure the blood pressure inside the veins, the heart, the arteries. It can also measure the blood flow and how much oxygen is in the blood. And then we can do a pericardiostentesis, and that helps us to remove the fluid and relieve that pressure that's been being placed on the heart. So what they do for that procedure is an echocardiographic or So we can do it under echo or fluoro, where they can actually see what's going on, right, in real time, in a real-time picture. While hemodynamic monitoring is being done as well, the cardiologist will insert an 8-inch 16 to 18 gauge pericardial needle, and it goes into the pericardial space. And when they get the needle in properly, once it's positioned, they can insert a catheter, and then any pericardial fluid can be withdrawn at that point. They can leave a drain in temporarily, but what we want to do is monitor the pulmonary artery, the wedge, and right arterial pressures during the procedure. All the pressures should return to normal as soon as we get the fluid that's pushing on the heart, that's compressing it, as soon as we get that out. And the other signs and symptoms as well should resolve. Sometimes if we don't know why the patient is experiencing the tamponade, then they'll take that fluid that they've withdrawn and send it to the lab for culture and sensitivity tests, as well as cytology. So they're looking at the cells. Cardiomyopathy, here we have cardio, which means heart, myo, meaning muscle, and pathy, meaning disease. So cardiomyopathy is a group of diseases, of subacute or chronic diseases of the cardiac muscle, sometimes without a known cause. But they all have to do with a weakening of the heart muscle and potential eventual heart failure. They're divided into 4 different categories based on the abnormality in the structure and in the function. Among the rarer forms, there is a genetic component as well. So things that we do for diagnostic purposes for all of these types of cardiomyopathy is an echocardiography, radionuclide imaging, and angiocardiography during cardiac cath to differentiate between the different types. Dilated cardiomyopathy is the most common type, and what happens here is that the walls of the heart become thinner because the heart chambers are dilated. Typically, it's the left ventricle that's the worst, but the walls of the heart are so thin, so systolic function, and remember that's the squeezing, is impaired. So more blood is staying in the ventricle, which leads to a decrease in cardiac output from inadequate pumping of the heart. So to compensate, the heart chambers, they blow up bigger, right? They dilate more, they become larger so they can hold more blood, so that they can try to get more blood out to the body. In time, though, the chambers can't dilate anymore, and that's when the heart failure occurs. So a lot of times this dilated cardiomyopathy leads to heart failure. There are some risk factors, things like malnutrition, infection, inflammation, alcohol abuse, and patients that have gone through chemotherapy. And then we have some signs and symptoms, and these really result from 2 things. One is the decrease in the ability to pump the blood forward, right? So the body's not getting enough oxygen, so we see things like chest pain, dizziness, right? Because the brain's not getting enough oxygenated blood. We could see syncope or fainting. There's also then, on the flip side, signs and symptoms of blood backing up behind the heart. So that's things like fatigue, weakness, dysrhythmias, heart block, emboli. We can have S3, S4 gallops, cardiomegaly or enlarged heart. So depending on where the structural and functional abnormalities are, the findings might be a little bit different. But in dilated cardiomyopathy, we see this left ventricular or biventricular failure. Patients are sometimes asymptomatic for months to years, and then it's when they go in for an x-ray for something else that we see that, hey, the left or the right ventricle is dilated. Other people, though, get the sudden pronounced symptoms of left ventricular failure, which, remember, left lungs. So then we see things like progressive dyspnea on exertion, orthopnea, palpitations, activity intolerance. In time, then right-sided heart failure develops, right? Because the most common cause of right-sided heart failure is left-sided heart failure, and that happens later in the disease process and is associated with a poor prognosis. We can see AFib as well in some patients, and that one is associated with an embolism. In hypertrophic cardiomyopathy, the heart muscle actually gets bigger. So this happens from problems with the heart muscle. Usually there's genetic abnormalities, which decreases the contraction ability. That causes the heart muscle to hypertrophy or grow bigger in an attempt to compensate. It can also affect the septum, which is the muscle there between the right and the left sides of the heart. So that makes the chambers smaller. The heart can't fill properly, so it can't pump out enough blood. Also, that enlarged septum causes a narrowing of the outflow tract from the left ventricle. And so this blockage happens intermittently based on how hard the heart is working and where we are in the cardiac cycle. It's often seen this obstruction in the left ventricular outflow tract is seen in patients with this hypertrophic cardiomyopathy. And again, it's really half of the time it's transmitted as a single gene autosomal dominant trait. So there's this genetic component, and some patients die without any symptoms. So this can happen just without warning. They might have syncope where they faint, become dizzy, have palpitations. A lot of athletes who die suddenly probably have had this hypertrophic cardiomyopathy. So primary symptoms: exertional dyspnea, angina, syncope. The chest pain is atypical in that it occurs at rest. It's prolonged and it has no relation to exertion, right? So it's not that they're exercising and get chest pain. It happens kind of out of nowhere. Also, if they take nitrates, it's not relieved. There's a pretty high incidence of ventricular dysrhythmias associated with HCM. And again, sudden death occurs, and that may be the first time that we even know anything about the disease. So screening is imperative, okay? It's really important that we're screening patients. We look for the systolic injection murmur that increases with the Valsalva maneuver. So when the patient is bearing down, the chamber gets smaller. The Valsalva worsens the obstruction and decreases the blood flow. We can do an echo to look at the septum, to look at the left ventricular wall thickening, and then they can do confirmatory tests like genetic tests, cardiomuscle biopsy. They can do a myofibrillar disarray where the muscle cells aren't lined up linearly, but instead they're kind of all over the place in different directions. And this disarray of muscle fibers is really what causes this hypertrophic cardiomyopathy in the first place. We've got a couple other types of cardiomyopathies. These are even less common than the other two. There's restrictive, where there's stiff ventricles. They can't expand then, so it restricts the muscle movement. There's pretty poor outcome, as you can imagine. The symptoms that we see are very, very similar to right and left-sided heart failure, or both. And then there's the arrhythmogenic right ventricular cardiomyopathy, or dysplasia, and that is where the normal healthy heart tissue is displaced and replaced with fatty and fibrous tissue. And so again, you can imagine that cardiac tissue is designed in just the way it needs to be. When it's replaced by any other type of tissue, it just doesn't work as well. Genetic component as well affects young adults, and sometimes it's asymptomatic. So interventions for cardiomyopathy, initially they're the same as for heart failure patients. So we give ACE inhibitors, we give beta blockers, we give diuretics, antiarrhythmics. We can also give vasodilating agents, cardiac glycosides, to help increase cardiac output. We want to refer our patients to support groups, assess for anxiety and depression. And then finally, encourage family members to get tested because as we discussed, it can run in families.